My name is Shelia Vakharia, and I'm here from the United States. I'm from an organization called the Drug Policy Alliance, and it is my deep pleasure to be here and privilege as well. Thank you to Kirsten, to Austin, and to Tricia for facilitating my visit and for bringing me here today. And I look forward to getting to know all of you as I stay here over the course of the day. So my presentation is about several things. First and foremost, I want to express solidarity with those of you who are in the room today fighting to save lives. We in the United States are also facing an unprecedented overdose crisis. We have lost over 1.1 million people to preventable drug overdose since our crisis began almost 25 years ago. And we on the ground, like you on the ground, are fighting in the face of government inaction, delayed action, inadequate action, and silencing. So thank you so much for all you do, and I am here in solidarity with you today. So I'm going to speak about the unfolding of our overdose crisis over the past 25 years and offer insights into what and what not to do and what you can learn from our experience. I want to specifically zoom in on the role of stimulant drugs in drug-related harms that have emerged both in the United States and, from what I understand, also here in Scotland. Some of the recommendations that my organization is trying to make to our local and federal officials in terms of how to really address stimulant drug-related harms. So I will talk a little bit more about drivers and solutions for stimulant-related harms, the important role of social determinants of health in increasing or exacerbating stimulant-related harms, and the public health treatment and harm reduction approaches that we need to ramp up or develop to help people who use stimulant drugs. I will then talk about why this moment calls for harm reduction, and why we need to focus on that specifically and the values and tenets and ethos that harm reduction offers us in this moment beyond what recovery-based frameworks offer, but beyond medicalization or spiritual disease model frameworks offer us, what specifically harm reduction has to offer us in this moment. And lastly, I will talk a little bit about the thesis of my book, which all of you have received copies of. I will not do a formal presentation, just a little overview, and for all of you who are interested in getting a signature, I will be here for the rest of the day if you'd like for me to sign your copy. So let's talk about this overdose crisis in the United States. Over the course of the 25 years of this crisis, what's really important to acknowledge is that it has changed form. It has unfolded differently geographically across the country. There has been a time or temporal shift in how it has unfolded over different periods. There's also been a demographic shift in the face of who is dying of overdose, racially and ethnically, but also in terms of age and socioeconomic status. And lastly, our overdose crisis has also been characterized by these distinguishing waves because of the drugs involved in deaths. So I'm going to describe our crisis over the course of 4 waves, because I think an understanding of seeing how it's shifted over time can help to better understand why we needed different tailored solutions at different moments, and that solutions for wave 1 being implemented at wave 4 may not have the appropriate effects. While I'm not sure if that's how you've framed your crisis, although it was very helpful to see the presentation, perhaps also this wave framework could be useful to you as well. So this first blue line is the prescription opioids. As many of you may have heard, in the United States in the late 1990s, pharmaceutical companies that were marketing so-called addiction-proof prescription opioids were gaining political and economic influence in the United States. They had a market over the ears of doctors and prescribers, and they convinced prescribers that their formulations of opioids were had relatively low abuse potential, and that opioids could widely be prescribed for various forms of pain that had otherwise not been treated with opioids, but with other types of analgesic medications. And over the course of several years of this heavy marketing campaign, this misinformation campaign, we in the United States saw astronomical numbers of prescriptions written for opioid drugs for a variety of conditions for which perhaps it was not necessarily appropriate, but also patients were not getting adequate information about risks for harm, risk for physiological dependence, risk for overdose. And so you can see here as this blue line kind of increases and goes up, that the involvement of prescription opioids marked the beginning of the overdose crisis. And in particular, prescriptions were being written in certain parts of the United States known as Appalachia, or the Rust Belt of the United States, a place where a lot of blue-collar industry, mining, manufacturing jobs were predominant, but also communities where these jobs had recently been outsourced, and a lot of disinvestment was happening in these communities. And at this time, the face of the overdose crisis was very deliberately white. These were white, middle class, or even working class people who were being prescribed these medications and dying at high rates of overdose. And what we can see is that as overdose deaths started to increase in these communities, officials and lawmakers and the public and the media were very concerned. And so what did we do when we started seeing people die at higher rates? Well, we called it a prescription opioid crisis. So when you name a crisis after a drug, you make the drug the problem. And so the solution is get rid of the drug, right? Let's crack down on prescribing, crack down on dispensing, and reduce the availability of these drugs. And then all of a sudden, people will stop dying, right? Because it's the drugs that are the problem. So what we started to do was crack down on prescribing, reduce dispensing. Yet what did we do? We didn't address drug demand. We didn't address the fact that cutting off supply wouldn't end the physiological dependence of people who needed those substances to function and to operate, many of whom were being treated for pain, perhaps for the first time adequately in their lives. And so what ended up happening was in cutting off a legally regulated supply, we just simply incentivized people to move to the underground market, where for a period of time there were enough surplus or diverted pills that were still available to be sold, but at quite a markup, right? And at the same time, around 2008, 2009, Colombian and Mexican drug trafficking organizations started learning how to grow heroin in their climates. And so in the United States, around 2008, 2009, we had Colombian and Mexican heroin in our markets. And they were actually, it was really good quality, it was quite affordable. And so sellers were able to say, we could sell you this diverted pill, but they're gonna get harder to find and they're getting more expensive. Or you could use powder heroin and you won't be sick, it'll tide you over and it's much cheaper. But again, bag to bag, day to day, the quality of that product was going to be a variable kind of that you couldn't predict. And so what we started to see was the beginning of what we call the second wave of the overdose crisis, wherein now those same white, rural, Appalachian, middle-class communities who now all of a sudden were being squeezed out of their prescribed opioid supply were shifting to the street heroin market. And again, this is where we started to see an increase in overdose deaths. And what did our officials decide to do? Well, it's an opioid crisis. We need to crack down on heroin. We started to see penalties increasing, more interdiction at the border, harsher penalties, more money towards drug trafficking organizations. And what did we do? We squeezed our heroin supply so much that now all these users weren't getting the supply that they were looking for. And what we saw was that the drug trafficking organizations realized we can't keep up with demand with the life cycle of a poppy plant because we can't just grow more fields and expect to have heroin tomorrow. However, in the 1960s, Janssen Pharmaceuticals developed a very highly potent synthetic opioid called fentanyl for the use of emergency surgeries, pregnancy and delivery, kind of rapid kind of need for opioid sedation, but also rapid need for it to wear off. And so they had developed this pharmaceutical, and to this day, still used in emergency surgeries, very quick surgeries where you need to kind of bring someone down and be able to operate quickly. And so the drug trafficking organization said, well, we can get the precursor chemicals from the dark web, and from other international sources. And we can mix up the supply so we don't have to worry about the life cycle of an opium poppy plant. And since it's over 100 times more potent than heroin, all we need are a couple granules mixed into every bag. And the end user will still get the high that they're seeking, and we'll still get our profits. And it'll be our way of making up for the fact that our supply chain has been squeezed, right? This is called the iron law of prohibition. The more we crack down on one drug, the more we incentivize the introduction of more potent, novel, easily discrete, trafficable drugs, right? Because what used to be several bricks of heroin could be one brick of fentanyl, which you could squeeze into a tire and drive across the border or even mail to yourself. And so fentanyl is this gray line that we started to see emerging in driving overdose deaths by 2013, 2014 on the East Coast, parts of Appalachia, where we had powder heroin. And as you can see here, what it also happened was that our existing heroin supply chains that had been entrenched in our inner cities across the country that had largely low-income whites and racialized minority communities, all of a sudden their reliable heroin supply just now became unpredictable too. So in wave 3 of this crisis is when we started to see racial and ethnic minorities dying at increasing rates of overdose. Our Native communities, our indigenous communities, started dying at higher rates. We started to see higher rates of overdose among our Black and African American communities, and we also started to see Hispanic or Latino communities having higher rates of overdose death, because these inner city drug markets aren't different than the rural markets. They're all the same markets. And so as soon as fentanyl entered all of our markets, we started to see entrenched users who'd been using street heroin for decades now dropping dead of overdose because their supply and the strategies that they had used to stay safe with heroin no longer applied in the world of fentanyl. And here we are now in the 4th wave of this crisis. And this light blue line is methamphetamine, a stimulant drug, and this yellow line is cocaine, also a stimulant drug. And now this 4th wave of the crisis that we're in is characterized not only by synthetic opioids such as fentanyl, but also stimulant drugs, so that fentanyl is the #1 drug involved in overdose deaths, followed by methamphetamine and cocaine. And about 50% of methamphetamine-involved overdose deaths also have an opioid on board, and about 70% of cocaine-involved overdose deaths have an opioid on board. And across the country, about 80% of deaths in our country as well are driven by opioid drugs. And so this 4th wave is a polysubstance wave characterized by stimulants and opioids, but also disproportionately impacting racialized and ethnic minority groups, so that as of 2020 with COVID, Black people have higher overdose death rates than white people nationally, and Native Americans have had higher rates of overdose than white people since 2018. And some of the strategies that we tried to implement again as we saw fentanyl-involved overdose deaths go up were harsher penalties. So under the Trump administration in 2018, the government decided to pass harsher penalties to fentanyl and fentanyl-like drugs. We made it even more penalized than they already were. And what did we see? Overdose deaths only continued to go up. The co-investment into harm reduction treatment and healthcare was not there, but there was more of an investment in supply side interdiction, right? And this is also notably when we started to see the emergence of novel sedative drugs and novel opioids, such as xylazine, which is a veterinary tranquilizer, nitazines, like you have also seen here, and etizolam, another sedative drug. Again, when we crack down on known drugs, we only incentivize the introduction of unknown drugs, because our drug laws are written with molecular formulations in mind, and so it basically tells traffickers, add a little hydrogen, add a little add a little molecular change, and then we'll skirt prohibition for a little bit longer. But the problem is that users don't get the memo, and they often end up being the ones bearing the brunt of an unknown and unpredictable drug supply. And then as you can see here, COVID-19 only exacerbated this crisis. In 2019, we lost over 90,000 people to overdose death. In 2021, we lost 100,000 people. In 2022, we lost 107,000 people. And in 2023, we lost 105,000 people. So 3 years in a row of losing over 100,000 people, and our government officials are patting themselves on the back because in 2023, we had a 3% decrease in overdose deaths. Tell that to every family member. Tell it to every loved one. It is not time in the United States to claim any sort of victory. 100,000 deaths per year to overdose cannot be our new normal. It is not something for us to cheer and celebrate. If anything, it's something that requires us to double down. Yet sadly, our harm reduction movement has experienced this loss even more profoundly. And I'm sure those of you in this room experience it more than others. You've looked around the room and your colleague who was there one day wasn't there. That participant who usually greeted you with a smile, you found out was found dead the day before. We are bearing the brunt of this crisis more than anyone else because those of us at the front lines are the ones dealing with this reality the most. And so, in just kind of telling you a little bit of the story of our overdose crisis, hopefully that offers some insights into the parallels, but also a cautionary tale for putting supply-side or drug-specific interventions at the forefront without the co-investment into health resources, or instead simply putting those resources into our communities to help support people. But let's specifically talk about stimulant drugs, which I've shown you are involved in a growing segment of overdose deaths in the United States, and which I saw from your data as well, is driving deaths in its own way. But before we talk about reducing stimulant-related harms, or any drug-related harms, let us remember that as harm reductionists, we understand deeply and profoundly that people use drugs for reasons. And those reasons are meaningful and important, and often involve survival, joy, pleasure, life. Wanting to alter one's consciousness is not new. It is not a moral issue, and it shouldn't be a criminal issue either. The desire to alter one's state of mind is natural. I had 3 cups of something to alter my consciousness so I could get up here. I'm very jet-lagged right now. And so, again, when we talk about drugs, we must remove the morality from the conversation, and we must be able to look at the frank facts. There are a lot of reasons why people use stimulant drugs such as amphetamines and such as cocaine. And many of them are recreational, but many of them are also functional and adaptive. And it's important to remember that the majority of us who use any drugs never met criteria for an addiction, will never meet criteria for an addiction, and even if we do meet criteria for an addiction, we'll likely never walk in the door of a treatment facility. And motivations for stimulant use for those of us who have not had the pleasure of experiencing these drugs include euphoria, energy, sexual awakening, productivity, focus, performance enhancement, increased confidence, a boost in mood, appetite management, managing side effects of medications, such as psychiatric medications that lead to weight gain and lethargy, but also managing the effects of being on medication-assisted treatment when sometimes you don't get joy the same way you used to. And we must acknowledge that stimulants, when mixed with other drugs, can be fun. If we can't acknowledge the reasons why people put drugs in their bodies, we can't actually start the conversation about helping them to stay safe, right? And it's important for us to talk about motivations because they're often overlooked when we only focus on overdose, when we only focus on addiction, when we only focus on harm and negative consequences. Look where your drug use got you. Look what you lost. Without actually acknowledging that every person who uses a substance is doing a cost-benefit analysis, and maybe in that moment, the benefit is worth the cost, right? So how do we talk about stimulant drug use and helping people who use stimulants to stay safe? First and foremost, as I just said, there are many wonderful reasons why people like to use stimulants, but we can also look at the social determinants of health and the environmental reasons that make us use some of these drugs more than others. And by social determinants of health, I mean the things that affect our health beyond just the fact that we take a medication. So the neighborhood we live in, our family environment, whether we were able to get an education and get a good job, whether we have good access to health care, whether we have recreation in our life, whether we have meaningful employment, right? These are all social determinants of health. And understanding that deficiencies in some social determinants of health can often lead us to seek out drugs to offset or to make up for those deficiencies, right? And so one thing that we talk about a lot in the United States is how prominent amphetamine and cocaine use is among people who are homeless or unstably housed. When you're on the streets in the middle of the night, it's actually really smart to be on stimulants because you're less likely to get raped, you're less likely to get robbed, you're less likely to be victimized. If we don't talk about the fact that homelessness and stimulant use go together like a hand in a glove, we can't really talk about reducing stimulant use. We also need to talk about job or income insecurity and the ways in which stimulants can help you work that extra shift. Stimulants can help you take on those extra hours. Stimulants can make you work through the pain of a job that no one else wants to do, but that will get you a couple extra bucks to make it through the night. We also need to acknowledge that stimulants are highly, highly useful for people who work high-demand jobs, both in the underground and above-ground economies. The ways in which we live in a squeezed, the people in the working class and the middle class are squeezed, where inflation makes living unaffordable, where people need to perform to be able to pay the bills. We also need to acknowledge that sexualized and gender minorities in many of our countries and in many parts of the world are also disproportionately bearing the brunt of stimulant-related harms. Chemsex is a very big part of queer and gay cultures, and oftentimes helping to support their needs specifically is not something that our programs think enough about. And thinking about the kinds of services that are covered or adequately covered to address pain and the kinds of challenges that our communities are facing, and the ways in which taking a stimulant or taking an underground opioid can help manage pain when you can't afford physical therapy, or when there isn't a physical therapist available, or you don't have time to go and get that surgery that you actually need. And so we must propose solutions at the policy level and at the programmatic level that actually match the kinds of needs that we're seeing, right? Because again, when we label a crisis or a problem as a drug-specific problem without acknowledging why people, the root causes of that drug use, we're only gonna reduce the drug, but we're not gonna get at the core root of the issue, right? And so what is it that we need? We need low-threshold housing, including housing first, right? I love the idea of residential treatment, but you know who goes to residential treatment? Homeless people. People who actually probably could have benefited from an outpatient program and just needed a place to lay their head, right? How many ways in which are we giving the more expensive option to people when actually housing them and seeing the low threshold services that could actually meet them where they're at may be actually more cost effective? But we also must acknowledge that people use stimulants and other drugs often to survive unsurvivable conditions. And so we need to decriminalize both survival industries, including sex work, but also low-level crimes of survival, such as low-level thefts and burglary and those kinds of things. Because again, we're not really getting at the root of what people are trying to meet the needs with, right? And our criminal legal system is no way equipped to deal with people, right? But we also need improved worker protections, improved paid leave and sick time policies. Again, when people are sick and ill and can't afford to stop working, stimulant drugs and illegal drugs of various kinds often fill that gap so they can continue to work, right? We also need to target for racialized and ethnic communities, but also sexual and gender minority communities as well, many of whom are disproportionately bearing the brunt of these harms. And we must remember three key things: that in order to reduce stimulant-related harms, we must first address the social determinants of health that exacerbate or create the conditions for these harms. but we must increase access to health services, including harm reduction and treatment. And lastly, we need to think of ways to reduce contact between these marginalized people who use drugs and law enforcement, and find ways to make sure that they have more, if not better, contact with our healthcare and medical systems. And when talking about access to harm reduction and treatment, I often use this quote from Shiloh Jama, a harm reduction advocate out of Seattle, Washington. One thing he does very astutely is call out all of us in harm reduction around the fact that our harm reduction playbook was built on opioids and opioid-related harms. And more specifically, that our playbook was built around injection-related harms. I understand that the cocaine use that's driving harms here, as well as in the United States, some of it is snorted, but a lot of it is smoked in the form of crack cocaine. And in the United States, methamphetamine is also a largely smoked drug. And what's really important for us to remember is that a playbook built around a specific drug class and the needs of someone going through withdrawal or having physiological dependence on that may look very different for another class of drugs. Yes, people do have physiological dependence on stimulant drugs, but there are other drivers for that kind of repetitive use. There's different kinds of binge use that happens. Oftentimes, if they are injecting those stimulants, they're injecting many more times than your average heroin user would. But oftentimes, they're also smoking. And if they associate harm reduction programs with opioid users and with injection, where do people who need clean pipes go? Where do stimulant users learn about, if I do take that pill that that friend offered me, it could have an opioid in it, and I should probably know what naloxone is, right? And for those who engage in polysubstance use intentionally, why can't they get all their needs met at the same program, right? And so I offer you some really great resources made by a friend of mine, Kat Humphreys, who works at the Harm Reduction Action Center in Denver, Colorado, in the United States, because I think not only do we do a disservice by not providing the tools that stimulant users need, but we don't actually know how to help give them information or education on how to stay safe. So I see you all are taking pictures. Just give me 1 second. I got 3 graphics. You might as well get them all in one. There you go. What you can see here are some infographics that she developed to really give more information to people who use stimulants. So here on the left is a harm reduction service provider's guide to methamphetamine and other stimulants. First and foremost, understanding brain chemistry, but basic harm reduction. If they inject, they inject more frequently, so they might need more needles. If someone is having a hard time on stimulants, we need to remove them from situations, help them de-escalate. We need to talk about the different kind of hydration needs of someone who uses stimulants. Also the ways in which to kind of keep them calm because it elevates blood pressure, it elevates heart rate, right? We also need to talk about giving them cool down spaces, places where they can chill, right? Here we've got guidelines for smoking kit distribution, right? Giving them gum so that you keep your mouth hydrated, right? Giving them supplies to clean in case they are sharing their pipes. We call them chore boy. Chore boy is a kind of foil, or not like foil, it's like it's a copper scrubbing for like pots and pans, but we tear it up and we stick it in as a filter so that when people are smoking in crack, the rock doesn't come into their lungs. So chore boy, and a wooden push stick so people can actually push it in, right? The need for condoms and lube. Again, sex is great, and sex is even better on stimulants. We need to acknowledge that. We need to give out safer sex equipment, right? And safer snorting materials in case people are snorting their drugs. And also some sort of stem or tip to put on their pipes, because depending on the drug that you're smoking, your pipe can get very hot and you can get blisters on your mouth. And when you pass it to your friend, because drug use is collective. Drug use is relational. People use drugs together with ones that they love. And they oftentimes, as a sign of intimacy, will share a pipe. How are we helping people make sure that they're not subjecting themselves or someone they care about to potential bloodborne or other infections? So having a tip to put on the end, right? The risk of hepatitis from sharing pipes. Having snorting kits and giving people information about why it's important not to use your apartment key why a credit card isn't the best cutter, why maybe snorting off of a toilet tank is not the best idea, right? And also, specifically, overamping. Do you use that term here when you have too many stimulants or maybe have what might be a stimulant overdose? Overamping is a term that we use in the United States to just talk about when maybe you're a little hopped up, right? You're a little bit elevated, your blood pressure's a little bit elevated, your mood might be a little bit more anxious, you might be starting to hear things or see things, you might have a lot of energy and not know what to do with yourself, your body might start spasming, or you might just kind of need to get up and move around. So we talk a lot about overamping safety. How do you identify the signs when someone is overamping? How do you intervene to keep them calm, to help de-escalate? How do you know when it's something that warrants a call to emergency services versus something that we can deal with here at the program? One of my friends, Haven, whose face we're gonna see soon, she talks about how when her clients on meth come in and they have a lot of energy, she tells them, we got a lot of cigarette butts out front. And they will clean up the corner with cigarette butts. They will clean those up. If there's something tedious that needs to get done, they will pack a harm reduction kit. We, again, as harm reduction providers, are used to chilled out people on heroin coming in for a program. But we need to think about, what do we do with the energy of stimulant users in our program? How do we create a safe space for them? And what a safe space for them looks like might be different than what people who use opioids need, right? And if you're a polysubstance user, it depends on the day, right? And so we really need to talk about stimulant-specific resources and support, using the law of attraction, or this idea, if you build it, they will come, to bring stimulant users and polysubstance users into our spaces. Because in the United States, at this point now, it's also a racial equity issue, with Native people dying at the highest rate of methamphetamine-involved overdose deaths, and Black people dying at highest rates of cocaine-involved overdose deaths. To not provide smoking equipment to bring them in the door of our program so they can get a Hep C test, they can get an HIV test, they can learn about naloxone, they can get fentanyl test strips, is doing a disservice and leaving out an entire community of people who use drugs who could be getting resources and support, right? And we need culturally specific outreach, whether it's for the queer communities or racial and ethnic minorities, or whether it's for the dock workers, whether it's for the people on the shipyards, whether it's for those people who are currently out of work. It's not just racial and ethnic or queer communities. We need to think about the different working populations or the different neighborhoods who are also facing these harms, right? And the need for overamping education and resources, because at the end of the day, we must see this crisis and these crises as not being only driven by a single drug, but we need innovative solutions that understand that people are having complex relationships with the drugs that they use. And in what ways is stimulant use a response to being undertreated with your methadone or buprenorphine? In the United States, we call MAT, M-O-U-D, medications for opioid use disorder, but essentially also, why is it that we're seeing such high rates of stimulant use among people on methadone? Is it because they're not getting dosed? Is it because they don't have enough joy and pleasure in their life? Is there something else that we're not understanding? Do they need to split their dose because they're going down too much when they first take it, but they still go into withdrawal? After 22 hours, after 20 hours? How do we help people navigate their drug use? And we really need to talk about decriminalizing and funding all drug using and drug checking equipment, right? Syringes are great, but it's not enough. We need to decriminalize and distribute smoking equipment, snorting equipment, at the very least as an engagement and retention tool. Because we need people who use all illicit drugs to feel comfortable in our programs, not just people who use opioids, right? We also need overdose prevention centers or drug consumption rooms that include spaces with ventilation. I had the privilege of going to the site in New York City where I was in the room as someone injected fentanyl in the cubicle over there and the attached private bathroom. But then I also was there as people were smoking crack, and I got to wave and say hi to them through the glass-paneled ventilation space that they were in. But we also need to expand evidence-based treatment approaches if we are offering treatment. Has anyone heard of contingency management? Hands? You don't have to say anything, you can just show me your hand. I understand we've got a shy crowd. Okay. Contingency management is a treatment approach that uses behavioral principles of If you do the desired behavior, we give you a reinforcement that is going to help you see that engaging in this behavior warrants a prize. One thing that we have to acknowledge is that stimulant use is incredibly rewarding. You get the hit right away. It's incredibly reinforcing. It's incredibly, as soon as you feel a certain kind of way, you'll use a stimulant, you'll feel the effects right away. And if we want to engage people with those kinds of patterns of use into services, we need to have treatment give them that same dopamine hit that their drug use did. And research has found that if you engage stimulant users into treatment and give them vouchers for showing up, or have some sort of lottery system where they can pick out, a ticket from a big jar where you can get a movie ticket, or you can get a hygiene kit, or you can get a gift certificate to your local supermarket or grocery store, or if you can get $5 in cash on the spot. Using those kinds of rewards, whether cash or voucher or some other kind of treat, actually helps people get that dopamine hit that they associate with treatment and outcomes that they want. And so we need innovative strategies. And Cochrane reviews, which are the biggest systematic reviews that kind of weigh the evidence of interventions, internationally have shown that based on research, contingency management is one of the best treatment modalities that we can fold into our treatment and recovery system to engage and reinforce people who use stimulants in starting to build a routine of coming to care, and showing up to group, and letting us know if they're running late, and making it to their appointments. And it is very controversial for some people, but the evidence speaks for itself, right? And we need to talk about a safe supply for people who use stimulants, including substitution medications or substitution alternatives. Because again, we've got a robust system in place for opioid users, but we don't have that same alternative for people who use stimulants. And we need better protocols when people are overamping so that all of our programs are equipped to deal with someone who's used a lot of stimulants without calling the cops, without calling EMS. Because if you have loving rapport with someone who's in crisis, they do know your name. They do trust you. They might be a little freaked out because there's someone standing behind you or there's someone whispering in their ear. But if you have that relationship, developing the skills in your staff to work with someone who might be in crisis when using a stimulant is a way to reduce the criminal contact between your users and the law enforcement officers, or even medical staff who may be well-intentioned, but also may just want to sedate the hell out of your participant, right? And we need to fund much more stimulant-specific research. As I said, we know protocols for overdose reversal. We know protocols for what best dosages work for people who are dependent on opioids. We do not have that knowledge base for stimulants. And as advocates in this space, we need to talk to our officials and say, we need a co-investment in resources and education and research into what works with people who use stimulants in our communities. How are we going to help them? How are we going to help keep people safe? Right? And I think I kind of have already talked about this, but really thinking about all the ways in which we can reduce contact with law enforcement in addressing stimulant and other drug-related harms. So what I think is really important is for us to remember that we must lead with harm reduction. Here on the left, we have an image of Haven Wheelock from Outside in Portland, Oregon. And she defines harm reduction as, when you walk alone and in the shadows, it is easy to feel lost. Access to harm reduction brings humans into the light and community. It empowers health, hope, and humanity. And if you want a more academic definition, I always look at Alan Marlot's definition. Harm reduction is a set of compassionate and pragmatic approaches for reducing harm associated with high-risk behaviors and improving quality of life. So why do we need harm reduction in this moment now more than ever, more than any other approaches? Because for one thing, what does harm reduction offer us? Thinking beyond the binary. Either you're clean or you're using, you're dirty, right? Is this drug test gonna be clean, is it gonna be dirty? Either you're using or you're not. Either you're addicted or you're not. Either you're in recovery as defined by my strict definition that includes abstinence from all mood-altering substances, or you're not. Harm reduction doesn't get into binaries. We don't look at people or their experiences or their behaviors in terms of binaries. We see everything as occurring on a continuum, right? So we've got a whole spectrum of behaviors that people can be engaging in. So your drug use for one could be more harmful, your use of another drug may be less harmful. And how do we kind of get you to a place to reducing the harm? But also acknowledging that not all use is problematic or abuse. That either or thinking, either you're abstaining or you're addicted, doesn't acknowledge the nuances in drug use. Harm reduction offers us an opportunity to acknowledge that people have complex, real relationships with the substances that they use, and those vary, right? And it can vary from drug to drug, from day to day, and we create a space for all of them, right? And we also acknowledge that harm is relative. Going back to my example of a homeless person using stimulants to stay up overnight because they have no place to live. For another person, staying up all night is in and of itself a harm, right? So if someone tells me they were using all night, and I might think, ooh, you got a problem, right? But if I don't understand why you did it within the context of your life, and that of course me being up all night on a stimulant could lead to some pretty tough stuff, but for you being up all night on a stimulant is why you survived, why you still woke up with all your belongings, is really important. And again, harm reduction creates a space for that because our traditional treatment and recovery spaces, they tell you what harm is. They already defined it, and most of our people are engaging in harm, right? Also, what I like about harm reduction and what harm reduction offers us in this moment is that it is concretely solution-oriented. It is creative, it is nimble. Every time you work with someone, it's going to look different. Again, our one-size-fits-all treatment and recovery playbook only says help looks a certain way. Positive change only looks like one thing. Instead, we as harm reductionists work with our folks every day. What is it that bothered you about your drug use yesterday? What scared you? What concerned you? Let's talk about that. How do we make sure that doesn't happen tonight when you walk out the door? And it's about thinking outside the box. And it's about us seeing that we can help people be safer around the environments that they choose to use their drugs in, the people they choose to use their drugs with, the supplies they choose to use when they consume those substances, and the state of mind that they're in when they decide to use those substances. The plans that they make for themselves when they're using so that they know they have a backup, right? And what I love about harm reduction is that we have things to offer even people who don't meet criteria for an addiction, because everyone can run risks with their drug use. But currently our treatment and recovery infrastructure is only built for people with diagnosable addictions. And that means we just leave social and recreational users in the wind, right? But another thing is that harm reduction offers us a new way of looking at what help and success look like. It brings people out of the shadows. We acknowledge that better is better. I am not busy trying to imagine what I want your drug-free life to look like 5 years from now. I want to say, I'm so glad to see you because I saw you last week too, and I know it's been 3 years since you walked into any sort of program. Every time you use a sterile syringe is a win for me. Any positive change is another kind of slogan that we talk about. We credit it to Dan Big, but actually John Zeiler from the Chicago Recovery Alliance was the one who coined it. But any positive change, rather than there is only one definition of success and you're not there yet. Change is not linear. Stages of change do not happen in delineated time frames that can be dictated by an outside entity. Someone may be in a particular stage of change or improvement for weeks, months, or years at a time. It doesn't mean we know where they're going to end up 5 years from now, but I'm really happy to see you, right? And what I think is also super foundational, and this is why I talked about stimulant use earlier and motivations for use, is harm reductionists fundamentally do not believe that you can take away something before you understand what you're taking away from someone. Don't take away what you can't replace means Don't assume that you could just give up your drugs and your life's just going to somehow be magically better. So many of our treatment and recovery systems are built around the idea that the drugs are the problem, and as soon as the drug is out of the way, then your life is ready to be built. Or you can recover to and return back to a previous state. But many people weren't fully healed before drugs came into their lives. Drugs were part of their healing. How do we decide and define a new way of living with people, right? And why do we assume that by taking away the drug that now we can build the person up? So many treatment and recovery systems are built around this idea. Take away the drug and then we'll build you up again. But harm reductionists will say, I don't want to take away what I can't replace yet. So let me keep seeing you while you're using your coping strategies, because your drugs might be part of that coping strategies. And as soon as we start giving you stable housing, as soon as you have a community who cares for you, as soon as you got that HIV test back and you realized you were negative, and now you realize that you can actually stay negative by doing all these other things, maybe now we can talk about, like, do we always need to self-soothe with opioids? Do we want medications in the picture? Do we want actually more visits with our kids? Do we want to explore other kinds of recreation or other coping strategies for stress? What I think is really important with harm reduction is we don't take away what we don't understand yet. And everyone has such complex reasons for drug use that assuming that we can just take away someone's drug use and expect them to be ready and vulnerable and just able to deal with the world is a setup for failure, right? And I think what's different between harm reduction and treatment is that treatment takes retention for granted, meaning that someone shows up for treatment. We just assume, and we make you feel like you really messed up if you don't show up for treatment. Whereas in harm reduction, we're always happy to see you. And we see retention as a sign that our services are working. The more people come back, and they bring their friends, the more we know that what we're doing is working. Whereas oftentimes most of our treatment systems, including the one that I was working in, we did a better job of kicking people out on minor violations, drug test results, 5 minutes late, not giving me a call to tell me that your car broke down, right? Those kinds of things. We make it so much easier to kick someone out of treatment and recovery than we do to keep them in. And so, again, that is why harm reduction is so important, and also that success is participant-specific. You tell me what success looks like, because my definition of your urinalysis results, you having trace amounts of a drug metabolite in your urine, doesn't seem to be a fair assessment of what actually is going on in your life, right? And what I like about harm reduction and what we offer with harm reduction is an understanding that no one person is going to need the same thing as the person sitting next to them. And so it's about fundamentally understanding that we must individualize and tailor what we do. And I will say this to you, abstinence is great. I'll say it again. Abstinence is great, but not everyone is ready, willing, or able to abstain. Not everyone's going to tell you that, yeah, sure, 5 years from now, I'm not going to use drugs anymore. And the answer to that question should not be the difference between you being able to get my help and not. And you not changing fast enough shouldn't be the reason why I get to decide you don't deserve to come here anymore, right? And so harm reductionists being willing to engage with people on whatever terms that they want to is super important in a system that's built to keep people out and make it really hard to stay in when you do engage in those services. And it's really important for us to think of our services as being on a continuum, right? So like inpatient residential being over here, outpatient, maybe once a month pharmacy visits for your methadone here, all of those kinds of steps, once monthly injectable buprenorphine here. But what do we have here for everyone else? This system only addresses a small portion of people. What about everyone else? We need these drop-in services. We need these walk-in services. We need places where people can use drugs. We need treatment programs that we can work on non-abstinence goals. We need all of these other things. Right now, our system is only about this big, right? And again, at the core, harm reductionists believe that no one is disposable. No one is disposable. Your life matters. Maybe using drugs is how you care for yourself, and I'd love to explore other ways for you to care for yourself too, right? And so let's talk a little bit about my book before I wrap up, because I went way over. Okay, so I kind of alluded to this already, but what is my book about? So I argue that in the United States, I don't know if you guys had anything like this, but I grew up in the 90s. I'm an elder millennial, and I learned about drugs when a uniformed police officer came into my classroom and opened this big case, which had like spoons and cookers and powders and baggies, and was like, these are drugs, don't do them. They'll hijack your brain, they'll turn you into a criminal, you'll die, all the worst things, right? And so I grew up with this just say no messaging, but it had an expiration date. As soon as, well, in the United States, we only drink alcohol at the age of 21. And I had my first sip of alcohol at 21. In the United States, we can legally buy tobacco products at 18, but I did not puff my first cigarette until I was 25. But as soon as those things happen, where was I left without my abstinence-only just say no education? I was left to figure out how to stay safe on alcohol. I was left to figure out how to stay safe when I used LSD at a festival. I was left to figure out how to stay safe when I used other drugs, right? Because we're so busy telling kids to just say no that the second that they use even the legal drugs, they have no tools or strategies or education or support or education on what to do to stay safe, right? Because the only other thing that we have is, in the United States, our abstinence-based treatment system, right? Those treatment modalities that I just spoke of. And in the United States, research shows that about 90% of people who meet criteria for an addiction do not receive treatment in any given year. So what are we doing? What is this, right? So I argue that that is the harm reduction gap. It is where people who said yes to legal drugs and illegal drugs fall. But it's also those who do not want, need, or seek treatment. And so what I argue in my book is that most of us live in the harm reduction gap. Most of us who use socially, occasionally, recreationally, those of us who've experienced problems but never walked in the door of a treatment facility, but also those of us who walked into a treatment facility and didn't complete it. In the United States, as I said, 1 in 10 people with addictions gets treatment in the past year. Only 40% of those complete that treatment episode. So 60% of people who start treatment in any given year don't finish it. They get kicked out, they drop out, they can't afford to pay for it, what have you. So what about those 60% who never finish that treatment episode? Harm reduction is a safety net for them. What about the 40% who finish treatment, but within the first year of treatment, research says 85% of them will still go on to use a little bit? But also, what about the fact that in the United States, 60% of people who get treatment in any given year have been there 2, 3, 4, 5, 6 times or more? How are we keeping people alive between treatment episodes? That's where harm reduction fits in. But anyway, I'll leave you all to read the book, and I went way over, and I'm gonna stop talking now.